Welcome back. Now we will discuss a very important topic, that is massive blood transfusion. First, what is the definition of massive blood transfusion? The first definition of massive blood transfusion is when we replace the entire circulating volume in 24 hours. Or number 2, if more than 10 units of blood given in 24 hours. Number 3rd is if more than 4 units of packed RBC or blood product are given in 1 hour. These are the three definitions which we need to remember for massive blood transfusion. So there is a massive blood transfusion protocol which is initiated whenever we anticipate that a patient would require such large quantity of blood. In massive blood transfusion, we will be giving 6 units of packed RBC, 6 units of fresh frozen plasma, and 6 units of platelet-rich plasma to the patient. Now, regarding platelet, this 6 unit can be condensed into a single bag. Like most of the time, we might be having availability of SDP, which is prepared by a pheresis, that is single donor platelet. The efficacy of the SDP will be equivalent to 6 units of platelet-rich plasma. Now, the ratio at which these products should be administered would be 1:1:1. And the first thing to be administered is PRBC to treat the acidosis component in the patient. Now, please understand the fact that we will not give platelets first in a bleeding patient, because in a bleeding patient, due to exsanguination of blood, there is hypoxia, there is acidosis, and therefore to neutralize that hypoxia and the acidosis component, we need to give PRBCs which will carry oxygen and will neutralize the acidosis component. So why are we worried about the acidosis component? Because the fact that acidosis will impair the ability of the blood to clot. That will worsen the coagulopathy in the patient. Now, please remember it's in a bleeding patient. It does not mean that we are talking about a dengue hemorrhagic fever patient who is having a low platelet count. By bleeding patient, we means it could be a obstetric trauma, it could be a surgical trauma, or it could be a hematomesis. Okay. So even if a single IV line X is available, the first thing that we will give to the patient would be PRBC, then fresh frozen plasma, and then platelets. See, there is a possibility that you may not use all of these components, because even before you give them these components, patient might start recovering. Now, the next point we are going to discuss about trauma-induced coagulopathy. Note the fact that trauma or blood loss itself will result in development of coagulopathy. Why? Because when you lose blood from the body, the person will start developing cold, clammy extremities. There will be hypothermia set up in the patient, loss of blood from the body, which leads to loss of heat. So hypothermia itself will result in decreased ability of the clotting system to function. So therefore, you will read the term trauma-induced coagulopathy, where a person due to blood loss because of the loss of the clotting factors from the body will be having the development of increased bleeding tendency. Now, to this, if you add massive blood transfusion, because RBC is stored at 4 degrees Celsius, when you give that cold RBCs to the patient, the hypothermia component will worsen, and this worsening of hypothermia component will further result in coagulopathy. Let us now understand the bloody vicious cycle. The bloody vicious cycle that will set up in these patients due to poor circulation. Patient will be having metabolic acidosis because the cell will switch to anaerobic mode of respiration. Along with this, when you will giving cold blood component to the patient, it will trigger development of hypothermia. And the third component is hypothermia will interfere with the clotting process. So it will result in coagulopathy. So this triad is a disaster situation in practice of any doctor, because one thing leads to another, and therefore it becomes very difficult to manage the patient. Suppose you resuscitated a patient with massive transfusion protocol, but when you rush so much of crystalloids followed by blood transfusion to the patient, the hemodilution component will occur in that patient. Hypothermia will be set up in the patient, and that will interfere with the clotting process, and that will worsen the coagulopathy in the patient. So one thing is leading to another. In fact, our resuscitation is contributing to trouble. So nowadays, to counter this dangerous situation, we have an inline warmer in a rapid infuser pump so that the blood components are warmed to a sufficient temperature to minimize the chances of hypothermia in the patient. Now, I will highlight one thing. Human body has a limited ability to achieve clotting. Because of all we have is 10 gram of fibrinogen and 15 ml of platelets. If you drain that out of the body, then the chances of patients dying is increased. Okay. In fact, clinical studies have shown if a person is having 150 ml of blood loss per minute from the body, then most of the time after 20 minutes, the amount of blood loss in the patient is so severe that he will go into decompensated shock. He will usually become pulseless or there would be thready pulse with non-recordable BP.